An overview of antibiotics for medical students. In this video, we will discuss groups of antibiotics, examples of specific antibiotics in each group, the bacteria they target, and the diseases they are commonly used to treat. This information will be presented in a teaching manner to help medical students understand and remember the material. Penicillins. Examples: penicillin G, penicillin V, amoxicillin, ampicillin. Bacteria. Effective against both gram-positive and some gram-negative bacteria. Specific bacteria: Streptococcus spp. Staphylococcus spp, not resistant. Neisseria meningitidis, Haemophilus influenzae. Indications: commonly used for respiratory infections, skin infections, ear infections, dental infections, and sexually transmitted infections like syphilis. Cephalosporins. Divided into generations, 1st to 5th. Examples: first generation, cephalexin, cefazolin; second generation, cefaclor, cefoxitin; third generation, ceftriaxone, ceftazidime; fourth generation, cefepime; fifth generation, ceftaroline. Bacteria. Broad spectrum, targeting gram-positive and gram-negative bacteria. Later generations have increased activity against gram-negative bacteria. Specific bacteria: Streptococcus spp, Staphylococcus spp, Escherichia coli, Klebsiella spp. Pseudomonas aeruginosa, 4th generation. Indications: commonly used for respiratory infections, skin infections, urinary tract infections, bone and joint infections, and intra-abdominal infections. Fluoroquinolones. Examples: ciprofloxacin, levofloxacin, moxifloxacin. Bacteria. Broad spectrum, effective against gram-negative and some gram-positive bacteria. Specific bacteria: Escherichia coli, Klebsiella spp, Pseudomonas aeruginosa, Staphylococcus spp. 3. Streptococcus pneumoniae. 4. Indications: commonly used for urinary tract infections, respiratory infections, gastrointestinal infections, skin infections, and bone and joint infections. Macrolides. Examples: erythromycin, clarithromycin, azithromycin. Bacteria. Effective against gram-positive bacteria and some gram-negative bacteria, as well as atypical bacteria like Mycoplasma and Chlamydia. Specific bacteria: Streptococcus pneumoniae, Streptococcus pyogenes, Haemophilus influenzae, Mycoplasma pneumoniae, Chlamydia trachomatis. Indications: commonly used for respiratory infections, skin infections, sexually transmitted infections like chlamydia, and atypical pneumonia. Carbapenems. Examples: imipenem, meropenem, ertapenem, doropenem. Bacteria. Broad spectrum, effective against gram-positive, gram-negative, and anaerobic bacteria. Specific bacteria: Escherichia coli, Klebsiella spp, Pseudomonas aeruginosa, Enterobacter spp, Bacteroides fragilis. Indications: commonly used for severe infections, including nosocomial infections, intra-abdominal infections, complicated urinary tract infections, and resistant bacterial infections. Aminoglycosides. Examples: gentamicin, tobramycin, amikacin. Bacteria. Effective mainly against aerobic gram-negative bacteria. Specific bacteria: Escherichia coli, Klebsiella spp, Pseudomonas aeruginosa, Serratia marcescens, Proteus spp. Indications: commonly used for severe gram-negative infections, including septicemia, pneumonia, and complicated urinary tract infections. Often used in combination with other antibiotics for synergistic effects. Tetracyclines. Examples: tetracycline, doxycycline, minocycline. Bacteria. Broad spectrum, effective against gram-positive and gram-negative bacteria, as well as atypical bacteria and some parasites. Specific bacteria: Streptococcus spp, Staphylococcus spp, Chlamydia spp, Mycoplasma spp, Rickettsia spp, Borrelia burgdorferi. Indications: commonly used for respiratory infections, skin infections, sexually transmitted infections like chlamydia, Lyme disease, and infections caused by rickettsii, such as Rocky Mountain spotted fever. Glycopeptides. Examples: vancomycin, teicoplanin. Bacteria. Effective against gram-positive bacteria, particularly those resistant to other antibiotics. Specific bacteria: Staphylococcus aureus, including methicillin-resistant strains or MRSA, Enterococcus spp. Clostridioides difficile. Indications: commonly used for severe gram-positive infections, including MRSA infections, complicated skin infections, and C. difficile-associated diarrhea. Sulfonamides and trimethoprim. Examples: sulfamethoxazole, trimethoprim, co-trimoxazole, sulfadiazine. Bacteria. Broad spectrum, effective against gram-positive and gram-negative bacteria. Specific bacteria: Escherichia coli, Klebsiella spp, Proteus spp, Streptococcus pneumoniae, Staphylococcus spp. Indications: commonly used for urinary tract infections, respiratory infections, gastrointestinal infections, and opportunistic infections in HIV patients, such as Pneumocystis jirovecii pneumonia. Oxazolidinones. Example: linezolid. Bacteria. Effective against gram-positive bacteria, particularly those resistant to other antibiotics. Specific bacteria: Staphylococcus aureus, including MRSA, Enterococcus spp. 3. Including vancomycin-resistant enterococci or VRE, Streptococcus pneumoniae. Indications: commonly used for severe gram-positive infections, including skin and soft tissue infections, pneumonia, and VRE infections. When determining which antibiotic to use, several key principles should be taken into consideration to ensure effective treatment and minimize the risk of antibiotic resistance. These principles include: obtain a bacterial culture and antibiotic susceptibility testing when possible. Cultures and susceptibility testing help identify the causative pathogen and guide the choice of the most appropriate antibiotic. Empiric treatment may be necessary while awaiting test results, but the choice should be based on the most likely pathogens for a specific infection and local resistance patterns. Choose the narrowest spectrum antibiotic. Select an antibiotic that targets the specific causative bacteria, rather than a broad spectrum agent. This helps minimize collateral damage to the patient's normal microbiota and reduces the risk of promoting antibiotic resistance. Consider the patient's medical history. Assess the patient's allergies, prior antibiotic use, previous infections, and underlying medical conditions. This information can help identify potential contraindications or drug interactions and guide antibiotic selection. Assess local resistance patterns. Knowledge of local antibiotic resistance patterns can help guide the choice of empiric therapy. These patterns may vary by region, healthcare setting, and even individual patient populations. Optimal dosing and duration. Ensure the chosen antibiotic is administered at the correct dose and for the appropriate duration to maximize efficacy and minimize resistance development. Follow evidence-based guidelines for dosing and treatment duration when available. Route of administration. Consider the most appropriate route of administration, oral, intravenous, etc., based on the severity of the infection, drug bioavailability, and patient factors such as ability to tolerate oral medications. Monitor clinical response. Continuously monitor the patient's response to treatment and adjust the antibiotic regimen if necessary. This may include de-escalation to a narrower spectrum agent, switching to a different antibiotic, or discontinuing antibiotic therapy when it is no longer required. Cost effectiveness. Consider the financial implications of antibiotic choices when possible, as some antibiotics can be more expensive than others. Choosing a cost-effective antibiotic can help minimize healthcare costs without compromising the quality of patient care. Pharmacokinetic and pharmacodynamic properties. Consider the drug's absorption, distribution, metabolism, and excretion, as well as its bacteriostatic or bactericidal properties. This information can help optimize treatment efficacy and minimize potential adverse effects. Here's an illustration of how a culture and sensitivity test is useful and how to understand local antibiotic resistance patterns. A patient presents with symptoms of a urinary tract infection, UTI, such as frequent urination, dysuria, and lower abdominal pain. The clinician suspects a bacterial infection and collects a urine sample for culture and sensitivity testing. The laboratory processes the urine sample, attempting to isolate and identify any bacteria present. After a period of incubation, bacterial growth is observed, indicating a positive culture. The isolated bacteria are identified, typically using a combination of biochemical tests and/or molecular methods. For example, let's say the laboratory identifies Escherichia coli as the causative organism. To determine antibiotic susceptibility, the isolated bacteria are exposed to different antibiotics in varying concentrations. The results, often presented as minimum inhibitory concentrations, MICs, indicate the lowest concentration of each antibiotic required to inhibit bacterial growth. The laboratory interprets these results according to established breakpoints and reports them as susceptible, S, intermediate, I, or resistant, R. The clinician receives the culture and sensitivity report, showing the identified E. coli's susceptibility profile. Based on this information, the clinician can now select the most appropriate antibiotic for treatment, considering factors such as drug allergies, side effects, and cost. To understand local antibiotic resistance patterns, clinicians and public health officials collect and analyze data on bacterial isolates and their susceptibility profiles from different healthcare facilities in the region. This aggregated data helps identify trends in resistance and informs the development of local treatment guidelines. If a specific antibiotic resistance pattern is prevalent in the local area, empiric treatment guidelines may recommend alternative antibiotics or combination therapy to ensure effective treatment while awaiting culture and sensitivity results. By considering these principles when selecting antibiotics, clinicians can optimize treatment outcomes, reduce the risk of antibiotic resistance, and improve patient care.